Good afternoon, everybody. Thank you for joining us today. My name is Rebecca Reynolds and I'm the Executive Director of the National LGBTI Health Alliance. I'm immensely proud to be able to welcome you to our national launch of Australia's first LGBTI suicide prevention and mental health strategy. This strategy has been developed over many years and through the sharing of many stories and many experiences in many forums. And I'm immensely proud to see and to be able to let you see the end result of that work today. I'd like to begin by acknowledging the traditional custodians of the land that we meet on today, both here in Sydney, but in wherever you are across Australia. I'd also like to acknowledge our LGBTI elders and community leaders, without whose effort and lived experiences we would not have the privilege of being able to do this work and deliver this work today. Welcome to the launch of our strategy. I would like to say thank you very much to Professor Dame Bashir, who has very graciously given up her time today to be with us to launch this important strategy. But I'd also like to say, while you can't see in the room here in Sydney, we have a small and intimate audience here, but there are over 280 of you joining us from across the country. You are policymakers, you are government department workers, you are health workers, you are nurses, you are teachers, and you are members of our community organisations. And we are so very proud that you are able to be here with us today. Today's event will focus on the launch of the strategy so that you'll understand the context in which it was written and the various details of the strategy and what that means. But we fundamentally, and as we go through the process today, remember and deeply affirm that this strategy goes beyond numbers, it goes beyond statistics, and it goes beyond theory. This is about our friends, our families, our organisations and our communities. It's about our lived experience and what is the lived experience of thousands and thousands of LGBTI Australians across the country. The Alliance itself exists to address these inequalities, but also to find ways to explain that people's bodies, their genders and their relationships go far beyond the acronym of the LGBTI. And I believe that this strategy does that, and I look forward to sharing it with you. So on that note, I would like to hand over to the chairperson of the Alliance Board, Phillip Ramos.
Thank you, Beck. Thank you, everyone. As the chair of the Alliance, I am honoured and privileged to be here today with you all around the country to launch this important strategy, to be part of the launch of this important strategy. My role this afternoon is to provide some context to the strategy and to let you know how it fits into the bigger picture nationally. I'm going to give you some information about what we know. We know these things because of our relationships, our research, our policies, our work. We know that LGBT and I people and communities are not homogenous. Each population in the acronym is distinct, and within each letter there is also variation. We know that stigma and discrimination often leads to mental ill health, self-harm and suicide. We know that LGBTI people and communities are at risk of poor mental health and suicide compared to the general population. We know that LGBTI people and communities, when they are provided with services and policies that are tailored to meet their needs, that's when they're provided with adequate care and inclusive care. We know that young people, transgender people, and people with an intersex variation are more likely to attempt suicide in their lifetime than their peers. We know that LGBTI people are more likely to have suicidal thoughts than the general population. We know that LGBTI people are more likely to engage in self-harm than the general population. We know that LGBT people are more likely to experience and be diagnosed with a mental disorder. There isn't much data around intersex in relation to that statistic. We know that LGBTI people are more likely to experience and be diagnosed with depression and anxiety. So what we know is not great news. Mental health and suicide prevention initiatives have routinely overlooked and underserved LGBTI people and communities. But this afternoon, we're launching this strategy, and this strategy is the Alliance's strategy merging out of the Mindout project. Mindout was established in 2011, and in a little while, you'll hear some more detail about that. What I'm going to let you know is that in the past 6 years with the Mindout strategy, the Alliance has been witnessed and been part of a significant shift in the understanding of LGBTI suicide and mental ill health in Australia. From the Mindout project, there has been so many partnerships and collaborations, and that's with mainstream organisations, with Mindout champions, with practitioners, with communities, with researchers, and with policymakers. So this strategy has been developed in response to requests from communities and organisations. The Alliance has had calls from organisations wanting guidance around best principles and practice. They've had calls from community members seeking access to skillful knowledge and care during their own difficult times. We know that LGBTI organisations are seeking to coordinate their efforts effectively and in a way that's going to meet the needs of their particular population group. So this strategy has been developed in the absence of a unifying framework to help organise LGBTI suicide prevention initiatives. So with this strategy, the Alliance affirms its ongoing commitment to LGBTI suicide prevention, and we look forward to implementing the strategy in partnership with you all. Now I'm going to hand over to Ross Jacobs and Sally Morris, who are going to give us some more information about the detail of the strategy. Thank you.
Thank you. So this strategy is a national framework for the prevention of mental ill health and suicide amongst LGBTI people and communities that specifically reflects and addresses the emergent needs of LGBTI populations in Australia. But when reading this document, it's really important to hold in the forefront of your mind that for LGBTI people and communities, poorer mental health and suicide isn't abstract. It's something that happens. It isn't something that happens to someone else, but it's an everyday reality. So not only is it the stories of our friends and our partners and our families, it's also our daily lived experience. And this is what this strategy is endeavouring to change. So to do this strategy outlines 6 strategic goals and actions. The first being inclusive and accessible care. And this is that LGBTI people will experience equitable access to mental health and suicide prevention services and receive support that's appropriate to their experiences and is also responsive to their needs. The second goal is around evidence, data collection and research. The goal is around establishing an evidence base about LGBTI populations that adequately represents their histories, their lives, their experiences, their identities, their relationships, and accurately recording LGBTI deaths by suicide. The third goal is around diversity of LGBTI populations. Diversity within and between LGBTI populations needs to be recognised and responded to with strategies and approaches that take into account their individual and unique needs. The fourth goal is around intersectionality and social inclusion. And this is about LGBTI people from across all populations, backgrounds and circumstances will experience an increase in social inclusion and a reduction in stigma and discrimination. The fifth one is around a skilled and knowledgeable workforce. The mental health and suicide prevention sector workforce will be knowledgeable regarding LGBTI people and skilled, confident and competent in responding to their support needs. And the last goal is around promotion and prevention. And this is that our mental health promotion and suicide prevention programs, activities and campaigns will address the underlying factors that compound mental health issues, mental health outcomes for LGBTI populations. One of the most significant things about this strategy is that it recognises, acknowledges and supports the diversity across, within and between LGBTI populations And it is the crystallisation of work undertaken by the National LGBTI Health Alliance within mental health and suicide prevention projects undertaken over the last 7 years by both Mindout and by QLife. This work has included consultations, community surveys, conferences, the development of frameworks, good practice guides and professional development resources, the development and facilitation of professional development training and community capacity building training. We've had our projects evaluated. We've been involved in collaborative and consultative work with both target populations and also with LGBTI organisations and project partners. And most significantly, most importantly, also the member organisations of the Alliance who connect us with the knowledge and experiences of LGBTI people throughout Australia. This strategy is clearly stating that LGBTI populations needs to be a priority within community-wide mental health suicide prevention strategies and mental health strategies, policy and programs, if the goal is to reduce suicides in all populations across Australia to be achieved. And so the improving the mental health and suicide outcomes of LGBTI populations requires a whole of community response. And this is significantly because discrimination, stigma, prejudice and exclusion are the key causal factors of mental ill health and suicidality for LGBTI people. And so addressing these social determinants is the best preventative measure. However, this isn't just the work of health services, but all sectors and communities can take steps ranging in size and complexity that can contribute to the prevention of suicide and mental ill health for LGBTI people in Australia.
Thanks, Sally. I just want to say that it's really nice to collaborate with someone with such obvious and infectious passion. And it's safe to say that everything Sally knows about suicide prevention and mental health could fill many more volumes of the strategy. So stay tuned for volumes 2 through 20. We're on the way. Sally's passion is fed into both a respect for the people we're attempting to represent and an urgency in terms of the ambitious actions the strategy outlines. Passion reminded me that the strategy is written about individuals and groups, people with histories, identities, bodies, relationships and cultures. In order to accommodate these infinite stories and individual variations, the strategy has adopted a principles-oriented approach to suicide prevention in particular. And all of the strategy actions Sally outlined just before are intended to be implemented alongside these underpinning strategy principles. Adopting the principles as a way to work means changing from needing an expert to guide every aspect of LGBTI work to being in an open stance. The principles are about assuming accountability and following through, and they are intended to be flexible enough to custom fit any setting. The principles enable change from both inside and outside dominant cultures, from within mental health organisations by professionals and by individuals acting under their own steam in their own work. Change from within community groups and by allies on behalf of others are part of what the strategy talks about. The principles aim to encompass everyone's story. Mine personally as a gay white male growing up in a rural setting where LGB people were jokes and T&I people were completely unknown. But suicide was a known outcome that all of us as youth in that setting knew as a reality. When we were summoned into a group room at school from time to time, a certain schoolmate would be missing. The tragedy for LGBTI people is that when death by suicide occurs, that person no longer has a voice, as we know all too well. Often, and we're often not counted as a queer person because their death occurred in total isolation with no public declaration of who they were. We hope the 5 principles make this outcome less familiar and help to maintain better mental health for all LGBTI people. The principles themselves are 1, intersectionality. This is the belief in the diversity of LGBTI people and communities as identified, acknowledged and respected, with individual experiences being recognised as fundamental to appropriate care. 2, evidence. Evidence must be informed from both practice and research and form the foundation of quality care to meet the support needs of LGBTI populations. 3, access. LGBTI people and communities must receive welcoming, equitable and inclusive care without encountering barriers to accessing support on the basis of their sexuality, body, gender, relationships, identities or history. 4. Lived experience. LGBTI people and communities are acknowledged as the experts in their own lives, which have been shaped by personal and cultural history of both stigma and resilience. And finally, 5. Social inclusion. LGBTI people and communities must be included in the fabric of Australian society through reducing discrimination, eliminating violence, and removing legal barriers that affect the ability of LGBTI people to experience connection. So these principles offer a flexible implementation across various settings. They open opportunities for creative and innovative response. They allow space for each population and community, Sally has already mentioned, to provide the key details for themselves necessary for unfolding the actions in the strategy. And going along with this, the principles are able to run alongside ongoing cultural awareness development and training. In launching this strategy, we make 3 calls. We call for coordination, we call for collaboration, and we call for commitment. The strategy requires a national coordinated response that supports efficient and effective implementation and delivery of actions across the mental health and suicide prevention sectors. Together, we must collaborate between levels of government, across sectors, and from the individual through the whole population. In doing so, we can develop achievable goals and reach them via a commitment to adequate resourcing for implementation and ongoing sustainability. Such commitments to this strategy at a national level will ensure that services and organisations throughout Australia are given clear guidance and strong support about the inclusion of LGBTI people in their care. Finally, the strategy acknowledges and supports the fact that sexualities, genders and bodily variations exist within cultural contexts, recognising important intersections, but not exclusive to Aboriginal and Torres Strait Islander communities, rural, regional and remote people, CALD groups, people living with disability and chronic illness, children and young people, older people, and families wherever in Australia they are and whatever they look like. Research and community discussion shows clearly that each of these contexts has an impact on the narratives and needs of populations and individuals. To conclude, a good policy is one that can be heard and understood by those it proposes to support. A good policy is one that anticipates the needs of each population and facilitates participation in productive change without undue stress on the individual. In short, a good policy is one that people can see themselves in, which I hope we have achieved today.
Thank you, Ross and Sally, for giving us that great insight and again deeply affirming that this is a strategy that goes beyond numbers and is about our lived experiences and capturing that. And this is about people and communities and support within those communities. And we are very grateful to have here today Professor Dame Marie-Bashir, who over such a long period of time has ongoingly worked and added her voice to advancing the health and wellbeing of our communities. So without further ado, please join me in welcoming Professor Bashir.
Thank you so much, Rebecca. Let me say to Rebecca, Philippa, Sally and Ross, all of you here today, I regard it as a deeply felt privilege to have been invited. I really do. And let me say, and I'm not being obsequious, a deeply felt privilege to have had the opportunity to work alongside, like a sister and a brother, with a number of people from your community, right across the health field, physical health, mental health, and certainly from them I received great inspiration. So this is a wonderful initiative that will add to the elevation, I believe, of Australia as a decent country who values all of its citizens. And just to digress for a moment to share with you some of the thoughts that have been with me over the last few days, knowing I would be joining you and not breaching any confidentiality. Some years ago when I was working full-time in the mental health field, somehow a number of people from the community individuals were sent to me for counselling because of profound depression and suicidal intent. Some were, in fact, from high school, and it seemed to me that these young people were in so many ways talented, insightful, every good quality you could imagine. There was one young man who felt he could never be accepted by his father because his father had to leave school in the Depression at the age of 14 because his mother was a widow and he needed to work to help put food on the table, literally. And he was this boy, he had two boys, one left school at the earliest possible opportunity and became a plumber's apprentice, and it was easy to understand. But the other one loved music, literature, the arts, as well as doing exceptionally well at school. So each Wednesday afternoon when he'd come to me for counselling and say, I don't think I'll be here next week, it took all the courage I had not to throw myself under the train today. And this went on. So one day he said, I nearly did today, and next time I won't be back here again, I won't be back anymore. So at that point I lost all my ethics, all my composure, and I just was left with the real person that loved this young man. I make no apology for that. They're old enough to be his mother. I said, I want you to know this, Andrew. When you're doing that, you will be throwing me under there with you, and I will never be the same again. And it wasn't meant to be that black barb or anything. He looked at me and he said, you really care about me. Do you really care about me? I said, well, look, I sit here Wednesday afternoons, and when you walk through that door, it's like the Hallelujah chorus, and the whole world looks better. So I said, anyhow, you with your brains, with your ability, your insight, you'll have to be a father to your father. He had to leave school at 14, you don't. I said, you go on, you could be a great doctor. Today, and I never hear from him, so I know he's absolutely wonderfully well. I don't mean professionally, I mean, yes, he's a specialist. The same thing has happened with others who become teachers. And with the insight, the sensitivity, as well as the strength and resilience, they have so much more to give, unconsciously as well as consciously, with all the people with whom they interact. So I've been greatly uplifted by what each of you have said, our four speakers. And I'd like to add something, if I may, and that is, we think about prevention. I would like in the classes of personal development at school, just sensitivity, not pussyfooting, but sensitive, saying we are all individuals, we are all different. Some are different to others, and that's what makes Australia great. So gently introduce that feeling so that we can absolutely eradicate marginalisation or a sense of difference, because we're not different at all. I certainly feel that from the bottom of my heart. So I want to applaud the courage and the openness of all of you and colleagues across our wonderful land. This will elevate it even more highly to embracing this national strategy of being aware and sensitive to mental health vulnerability and being able to provide sensitive inroads so that the best of interaction takes place, where suicide, depression, they are abolished. We're an upwardly mobile society. Most Australians want to do more and do better for their community, not only for themselves. And that exacts the toll. And what will rectify the toll is knowing that you're valued, you're cared for, and in fact you're integral to the greatness of Australia. So I applaud those who have initiated this and all those across our land who will ensure that this strategy goes from strength to strength. Thank you all for including me. I regard it as a deeply felt privilege.
Thank you so very much. It's wonderful to have you here and to have you speaking to everyone today. And I think you're very right in what you said, that while we have a framework that enshrines a series of practices that we want to build on in Australia, we have a long way to go and a lot to learn. And we have many people to bring with us on that journey. So thank you for being here to help us start that today. I guess that means that the work of this strategy has now officially begun. That while it creates a national framework, we now need to delve into the details and look at the intersections, find the nuances, and find ways to make our communities better for that by bringing everyone with us who needs to come with us on this journey. And I believe that this strategy lets us open and start those conversations and to start that work. I reiterate the calls from Ross and Sally around working on this strategy in a coordinated, collaborative and committed way, so that in 5 years' time we actually see a difference in our country and in the lives of everyone who is impacted in this important area of work. I would particularly like to thank the members of the working groups of the Alliance over many, many years. Those working groups have shared their stories, shared the ways that they have addressed their challenges and the discrimination and marginalisation that they have experienced not only in the mainstream mental health and suicide prevention sector, but within our own LGBT and I community organisations. And all of those stories and all of that knowledge has made this document stronger. I particularly would like to thank Danny Wright-Toussaint, Atari Metcalf, Vanessa Watson, Morgan Carpenter, Kristen Davis, Jude Comfort, Ben Tinman, Christine Morris, Sarah Lambert and Sean Miller, who helped guide particular parts of this strategy in its years of development, but also to our member organisations across Australia who have helped us to do that. In the coming weeks, we will be sharing this webinar and the strategy online. I think it's already on our website. Yes, I'm getting the nod. And feel free to contact us through our website if you have any questions around training or implementation of the strategy. And we sincerely look forward to collaborating with you to make this strategy a reality. So, not to those in this room, but to those of you around Australia, thank you so very much for joining us today, and we look forward to talking with you into the future. Bye-bye. And we're done.